Thank you all for attending, and hopefully we're going to get a few more people pop in. Now, as I mentioned last month, we sort of went across the pond to England, and this month we're back on American soil in New England, which is, of course, with a wonderful Beth Israel Deaconess Medical Center panel in Boston. Next slide, please. So, as always, I'm very grateful for our team, as described there. Next slide, please. This is our disclaimer. Next slide. So I've been told that Bostonians like to brag about being the first. So first subway, first public park, first public school, first university. I actually think it's truly amazing that it's such a beacon of academia, having 35 different colleges in the same city. I also found out that Boston has 47 miles of coastline, which I guess coming from Australia is better than nothing. Next slide, please. I'm indebted to Dr. Kristen Crowley for helping organize this event. So Kristen commenced being an attending in this institution following completion of her colorectal fellowship in the Cleveland Clinic. That's where I was fortunate to meet her. And she emailed us and was very proactive about hosting a journal club. And I would urge others, hopefully others that may be watching this on the DC&R YouTube channel, to take her lead and contact us via the email. Kristen, if you can kindly introduce your faculty and say a few words about your institution, that would be fantastic.
Hi, Vlad. Thank you so much for having us. Vlad, I wouldn't mind if you went and just quickly showed the beautiful views of Boston while I start to introduce our awesome crowd, because who doesn't want to live in Boston? At one point, you spoke about another institution and said, come to Australia for great coastline, but who would have thought that in Boston we actually had beaches? That was one surprise to find out here. But this is a nice picture of our division. It's led by Dr. Evan Messaris. You can go to the next slide now. Dr. Messaris moved from Hershey with me, and I met him. I've known him for 10 years. He's an excellent surgeon. He's a specialist in IBD, and we are fortunate enough to get to hear some of his advice, opinions, and experience at the end of this presentation. My other partners are Dr. Thomas Cataldo. He'll be a panelist discussing one of the papers later in the presentation. And our other partner is Dr. Ann Fabrizio, and she's out on maternity leave as of today. Some of our residents who are both applying for fellowship this year are Michelle Faulkner and Daniel Wong. They are excellent residents. They're superb. You'll hopefully get to see the programs that have fellowships, their applications come across, and our great recommendations letters for them. And our current fellow is Jeremy Dressler. He'll also give some insight. He is going to Vermont next year. So we'll hopefully hear some of his advice and what he's learned this year too. So thanks for having us.
And I also tell you that our future fellow looks like he's on the call as well. So Eric, you're going to come to us very smart.
Fantastic. Next slide, please. So we're going to start with a poll, and we're going to discuss this a little bit later, but essentially one of the studies that we shared on Twitter this month pertain to the pre-operative opioid analgesia that patients with Crohn's disease may be on for 6 months before surgery, and how it affects their overall recovery. So if you could please read the question and tick what you think is the most appropriate answer. And whilst we're doing that, perhaps we can go to the next slide. So our first paper written down here is what factors are associated with the eventual need for an ileostomy after total abdominal colectomy, and iliosigmoid versus ileorectal anastomosis for Crohn's colitis. Also very grateful for, I think, Dr. McKenna, who's made an effort to join us. It's always fantastic to have authors of the articles coming to Journal Club, which I truly believe is a very unique thing. All right. Now, without further ado, so we've got wonderful presenters, Daniel Wong and Kristen Crowley. So Daniel, please go ahead.
Good evening, everyone. Just want to make sure you can hear me, and thank you for the opportunity to present the paper. Always intimidating to have the lead author on the call, but I hope I do it justice. Next slide. So we know about 30% of patients with Crohn's disease have isolated colonic disease. The surgical therapy for these patients ranges from segmental colectomy to total proctocolectomy, depending on a number of factors, including indication for the operation, the extent of the disease, particularly if there's rectal involvement, and patient preference. Patients who undergo either iliorectal or iliosigmoid anastomosis and restoration of intestinal continuity are at risk for recurrence or complication, and a proportion of these patients require either permanent diversion or proctectomy. Unfortunately, risk factors for these negative outcomes are poorly understood, and moreover, the adoption of biologic therapy has likely altered the natural history of both pre- and post-operative Crohn's. Therefore, a reassessment of outcomes in a modern cohort was needed, which was the knowledge gap that the authors set out to address here. They aimed to delineate the ostomy-free survival in patients who had undergone colectomy with either an iliorectal or iliosigmoid anastomosis, as well as uncover risk factors for requiring a permanent ileostomy or proctectomy. Next slide, please. The authors conducted a retrospective cohort study of patients undergoing colectomy due to Crohn's colitis with iliosigmoid or iliorectal anastomosis at the Mayo Clinic in 2016-2018. Patients undergoing segmental colectomy were excluded. The primary outcome was ostomy-free survival following restoration of continuity, and some of the secondary outcomes included both perioperative complications and risk factors for requiring proctectomy or diversion. Next slide, please. Here are several of the tables illustrating the cohort characteristics. I'll just highlight a couple of big ones. The overall cohort consisted of 106 patients. Notably, about 10% of the cohort had rectal involvement at the time of operation, and just over 40% had been on preoperative biologics, characterized as having a biologic within 3 months or 12 weeks of surgery. The indication for colectomy was medically refractory disease in approximately 80% of the patients. 10% of the colectomies were due to dysplasia, malignancy, or cancer prophylaxis, and notably, almost 10% of the colectomies were due to colonoscopic perforation. The cohort was about 50-50 for iliosigmoid and iliorectal anastomoses, and then sort of importantly, what we're here to talk about, if we just advance the slide, we'll sort of highlight something. The distal pathologic margins were positive for microscopic disease in just a third of the cohort. They were negative in 30% and not commented on in about 40% of the cohort. For the sake of the analysis, that group that didn't have pathology commented on was included in the negative group. And then proximal margins were positive in 27% of the, distal margins were positive in 27% of the iliosigmoids and 38% of the iliorectals, which was not significantly different. On the far right are some of the perioperative outcomes, sort of notably just that there was a 4% rate of intra-abdominal septic complication, and that's about it. So next slide. Here's sort of the meat of the paper. This is the Kaplan-Meier curve demonstrating the primary outcome, which was ostomy-free survival for the whole cohort. Sort of overall, of the 106 patients, 16 ultimately required diversion or proctectomy. The most common reason is for 13 of 16 of those patients was Crohn's proctitis. The median follow-up was 3.1 years, and ostomy-free survival rates was 78% at 5 years and 60% at 10 years. But as you can see, sort of numbers at risk were started to dwindle pretty significantly after 6 years. As far as sort of this being in the biologic era, notably at last follow-up, about half the patients were on biologics, 40% on immunomodulators, and 15% were on corticosteroids. Next slide. The authors did examine some individual risk factors. So here are some Kaplan-Meier curves looking at risk factors including tobacco use, margin status, the indication for disease, either medically refractory or dysplasia, and the phenotype of the Crohn's, and you can see sort of some of the differences. And then next slide, please. After sort of those risk factors, really just distal microscopic margin remains significantly associated with a higher risk for requiring ostomy. And this significant hazard rate persisted through adjustment for smoking. Next slide, please. So overall, sort of take homes from this is that the survival rate without an ileostomy for an iliorectal or iliosigmoid anastomosis after restoration of continuity is about 80% at 5 years and 60% at 10 years. And in this analysis, the only risk factor for failure was positive distal margin at the time of resection. That's it for me.
Vlad, I think you're muted if you're trying to chat real quick.
Sorry. Well, I was going to go to you anyway to give us some pearls and your view on the paper. Thank you.
Dan, great summary and presentation on this topic, because I think ileocolic Crohn's disease is studied pretty well. However, what we should do about Crohn's colitis is still, I think, confusing and still needs to be evaluated with research and data a bit more. And so this paper doesn't even focus on segmental colitis. It seems like they say, hey, we know what to do with segmental colitis, but what about patients that have rectal sparing disease? You know, what can we do with them instead of giving somebody a permanent ileostomy? And so I think it's a great overview and kind of asking some of the questions, you know, what should we look at? Should we look at distal margin? Should we look at perianal disease? Should we look at the common risk factors of smoking? And so I think this paper starts to set us up for some of the additional studies that we can start doing with Crohn's colitis and optimizing our care in that area, since, you know, a lot of patients have just colonic involvement, 30%, where, you know, we focus the majority of our studies on the ileocolic disease. So I found it pretty interesting that even with perianal disease, you know, we won't do iliopalchainal anastomoses, but if they have rectal sparing disease, it seems like these patients can still undergo an iliosigmoid or an iliorectal anastomosis. I found it pretty interesting that 21 patients started out with perianal disease, and of those 14 still had their anastomosis at the end of the study. So I would think that perianal disease might exclude patients from undergoing iliorectal or iliosigmoid, especially with the increased diarrhea. But it seems like these patients still have, you know, their anastomosis in the study. And then I also found it pretty interesting about the biologic therapy, that only 50% of patients were on biologic therapy. I think it'd be interesting to stratify it a little further as to those patients that were that had positive distal margins, to see if those were the patients with biologic therapy and if that was able to salvage the anastomosis, since we use postoperative biologic therapy in ileocolic Crohn's disease, if we should be using it in colonic Crohn's disease when there's a positive margin. So I think this paper sets up additional questions for us to study and can kind of targets further studies.
Thank you very much. Now, if I could possibly go to Dr. McKenna, who's kindly attending, to kind of give us his take on what he thinks are the most salient points that he wanted to sort of get the audience to appreciate from the paper that they wrote.
Oh yeah, thanks for having me. I think a couple of things. One is just the overall rarity. We're fairly busy in Rochester, and we do maybe 10 of these a year. So I think it highlights the need for kind of multi-institutional collaboration in order to accrue bigger numbers and do better studies, more along the lines of the ileocolic studies that are out there. I think the other point was that this positive distal margin, it didn't differ between iliosigmoid and iliorectal anastomosis, so you shouldn't really alter your resection margin based on the microscopic margin, but really the need to increase surveillance and probably increase medical therapy postoperatively in these patients with a positive margin to try to prolong disease-free survival, I think was our kind of key takeaway.
Thank you. There are two questions from the chat that, again, having an author here is fantastic. We might as well pick your brain. Now, what are your views on quality of life with one of these anastomoses? That was one question. And the other one was, did you guys evaluate dysplasia or malignancy in the rectal conduit?
As far as quality of life, we were kind of limited being retrospective. We looked at bowel movements reported at last follow-up, and they're fairly similar between iliosigmoid and iliorectal anastomoses, but small sample size. Obviously, the more rectal stump you can leave, the better. And then as far as any dysplasia or malignancy in the distal rectum, we didn't observe that, but also kind of short follow-up, so could obviously develop down the road.
Thank you. Now, I've got a couple of questions to the panel. And again, if anyone else wants to post questions in our chat, that would be fantastic. The first thing I thought was interesting that I want to sort of explore is the difference between the iliosigmoid and iliorectal anastomosis. Specifically, the frequency of the iliosigmoid anastomosis was a bit greater at 54%, and these were often hand-sewn, as far as I gather. Now, my question to the panel is, when would you avoid an iliosigmoid anastomosis and why? Kristen, maybe you can pick whoever you think is best to discuss that from your faculty, as you know them much better than I do.
Perfect. So I'll start with, although it's rare, any patient that has significant diverticular disease, I would definitely exclude. But then I think that also shows that their colon in that area is also not diseased. But I'll take the question to Dr. Messaris and let him give his opinion on the difference between an iliorectal and iliosigmoid.
I think in this case, the critical part is, disease involvement. Okay, the first thing I would say is a rigid proctoscopy preoperatively with biopsies to confirm that at least we have either mild activity or no activity in the rectum. And I'm talking about 15 centimeters from the anal verge. That's the first step to be sure that your iliorectal or iliosigmoid is going to be successful for this patient. Then when don't we use iliosigmoids? I would say severe diverticular disease, or if you find Crohn's that is clinically significant intraop that you couldn't see initially endoscopically. And if you're doing it for dysplasia, because I saw, I think 17%, 20% of the patients had dysplasia. And of course, we all know that, the appropriate operation is total proctocolectomy. However, I assume after discussion between the primary surgeon and the patient, the decision was done to do a total abdominal. So I suspect that they did more iliorectals in the dysplastic patients to avoid leaving as much as colon as possible. I still believe that iliosigmoid has a better functional outcome than an iliorectal. And essentially dysplasia and significant diverticular or inflammatory bowel disease would be the two cases where I would not do an iliosigmoid.
Okay, thank you. That's very comprehensive and clear. The second question with that is related to the type of anastomosis. Particularly for the iliosigmoid, are we talking about an end-to-end hand-sewn? And would you factor in the anastomotic construction and potential scoping in future, particularly if you mention that there's dysplasia? Is one anastomosis easier to survey than another?
I guess by default, I'll chime in. I'd also answer the other question from my point of view is, I'm much more about function. So if the person's sphincter isn't perfect, they're either going to get an iliosigmoid if I can do it, or they're going to get an ostomy. I mean, because everything else is really about function. And I'm just going to generally assume that a lot of these people that are getting less than complete proctocolectomy are people that have refused stomas. So if they come in and they start out with the idea that I'm going to refuse a stoma, it's a different patient population, right? So there's a selection bias there. So I wanted to chime in on that. I am a rabid fan of an end-to-end anastomosis in the sigmoid or in the rectum for sure. I don't like doing an end-to-side anastomosis in the because I think you get a certain amount of stasis when you're stapling side to side, and there's tension on the anastomosis even if there isn't tension. So I'm going to make it end-to-end either way. If I can staple it, I'll do it with a reasonable caliber, but if I can't, I'll hand sew it. And I also keep in mind, not least of all, because we had Neil Hyman speaking at the New England Society of Colorectal Surgeons just yesterday, that in his series with my brother, the anastomosis with the highest complication rate is the iliorectal or iliodistal sigmoid. So I fear that anastomosis greatly. I don't know why, Neil didn't know why, but I still feel that here, I fear that anastomosis, even not an inflammatory bowel disease. So I would do it end to end any way I can.
Thank you. Professor Raskin, I think, has put her hand up, so we'll get to her in a moment. But before that, I just want to take you up on that fear of the anastomosis a little bit further. And specifically, when we talk about microscopic positive margin, whether, I've never really looked at it in terms of how it changes my decision-making in the immediate postoperative setting. But would your views for restarting biologics differ between an colic versus an iliosigmoid or rectal anastomosis? And also, does this microscopic margin increase your anxiety about the anastomosis, or is this more of a statistics thing?
Well, raise your hand if you get frozen sections during inflammatory bowel disease surgery, because I don't. So you don't get the answer to the question until a week after surgery. So you don't have much choice, right? You don't have the information to make a decision. I think the decision on whether or not to start the patient on biologics, I never just sort of defer it to the GI docs, but I think the decision about whether or not to start biologics after an operation like this should be made before you do the operation. And you have a plan in mind about what you're going to do with biologics before you do the operation, not based on whether or not the margins are microscopically positive or not. I don't know if that answers the question, but that's my answer.
Thank you. Now, Professor Raskin, I'm sorry for keeping you hanging.
No, quite all right. I was just going to chime in that reasons not to do iliosigmoid, iliorectal, one of the big factors for me at least is quality of life that I anticipate for the patient, what their expectations are, but I also really want to focus on their nutritional status. So if this is a patient who's been kind of wasting away, someone who has a poor acute or poor chronic nutrition, it's not the right anastomosis for all the reasons that we saw in the Hyman-Cataldo paper on iliorectal anastomosis. But the other thing I wanted to mention is what factors into my decision-making is not necessarily the microscopic mucosal or bowel wall involvement, but is the quality of the mesentery. And I think that's an area we really need to spend a lot of time on, is thinking about where Crohn's disease can also be present, and it's the mesenteric presence of the disease that can really be associated with recurrence. So I think we need to be mindful of that as well. So if the mesentery of the rectum or the sigmoid is hostile, we have to keep that in mind, that will be one of those reasons that it could recur more readily.
Thank you for that. One last question I have about this paper for discussion, unless anyone else has anything else. I've noticed, 73 out of the 90 patients with anastomoses at last follow-up, so that's 2+ years, were on 15% of those were on corticosteroids. As far as I understand, we're not talking about budesonide or some sort of enemas. I think this is systemic steroids. To me, it seems quite high. Now, Dr. McKenna, maybe you can shed light on that. What is your view on that stat?
And we're just catching at their last follow-up. So I think those people have just had an active flare within a few weeks of their last follow-up and were on either a short course of steroid taper. It wasn't kind of a long-term systemic steroid protocol.
Okay. Fair enough. Thank you. Okay, so now I think this paper has been fantastic, and thanks everyone for the discussion. Perhaps now we can move on to the next slide. Now our next paper is surgical techniques and differences in postoperative outcomes for patients with Crohn's disease and iliosigmoid fistulae. And the presenters are Dr. Faulkner and Professor Messaris. So, I'm sorry, no, Dr. Cataldo. That's been changed, I think, for the better, no doubt. Okay, Dr. Faulkner, maybe you can start when you're.
Yes, thank you so much for having me. I'll echo Dan. It's very lovely to be here. And tonight I'll briefly summarize the research published by Dr. Fenner and the group at Mount Sinai concerning surgical management of iliosigmoid fistula disease in the setting of Crohn's disease. Next slide. Iliosigmoid fistula disease arises primarily from diseased and inflamed TIs that adhere and ultimately penetrate into adjacent sigmoid colon. Approximately a fifth of patients with fistulizing Crohn's disease have iliosigmoid disease identified intraoperatively or preoperatively. In this context, the focus of the study is to very specifically compare surgical techniques in the management of iliosigmoid fistula disease. Open versus laparoscopic approaches are compared, and primary sigmoid repair versus sigmoid resection are compared in isolated iliosigmoid fistula disease. Next slide. The authors offer these figures as visual representation of en bloc resection. You can see in figure 1 versus primary sigmoid repair with iliocecal resection represented in figure 2. They have a stapler shown here, but they also include hand-sewn sigmoid repair in their study. Next slide. As the title states, this is a single center study using chart review data collected over 7 years. With regards to exclusion criteria, the authors noted that they identified 84 cases but had to exclude approximately 150 cases due to multifocal fistula disease. Next slide. Here they offer their results. Table 2 shows the characteristics of these 84 surgeries. Of note, 20% were open and 80% were attempted laparoscopic. Of this total group, 20% fell into lap converted to open. 60% underwent fistula takedown and primary repair, and 40% underwent en bloc resection. As Table 6 indicates, there were no significant differences in postoperative complication rates between open versus lap approach, nor between primary sigmoid repair versus en bloc resection. Ultimately, as Table 5 shows, there was only a difference in length of stay between the primary repair group and the resection group. Next slide. Within the limitations of a cross-sectional study, there does not appear to be a significant difference in outcomes between the en bloc resection group and the primary sigmoid repair group, nor between the lap versus open approach groups. As noted prior, the significance only emerges when considering length of stay in the latter comparison. Of note, stoma creation was significantly more likely in patients who underwent en bloc resection as compared with those who underwent isolated ileocolic resections with primary sigmoid repair, and that was a significant difference. Ultimately, when feasible, the authors advocate primary repair. They do, however, offer a treatment algorithm, which you can see on the screen here, for managing isolated iliosigmoid fistula, incorporating patient-specific features that should nudge surgeons to consider en bloc resection or diverting stomas. And you can see here if the sigmoid has active Crohn's disease, if there's a large phlegmon present or a large fistulous defect, the authors hypothesize that that might be a time when we should consider en bloc resection. And then kind of as noted in the prior discussion, if there's a patient history of poor nutritional status, immunosuppression, et cetera, that might be an appropriate candidate for diversion. Thank you for letting me present.
Thank you very much for that. That's very succinct and very clear. Can I now please continue and get the opinion of the faculty on this? So Dr. Cataldo.
So unfortunately, we don't have the authors with us, but I would, congratulate the authors for basically demonstrating that their institution has a tremendous experience with surgery for Crohn's disease. They even mentioned in their paper that one of the first large case series for this particular problem was published by them many in the 1970s or earlier. And I think that really is a tribute to demonstrating that large institutions with good reputations for individual diseases, it being inflammatory bowel disease or colon cancer or anything else, have excellent outcomes because of the concentration of experience. Also noting the concentration of this experience, the author notes that although there are 9 surgeons involved in the collection of the patients, 2 of them are responsible for the significant majority of the cases. And I think that that's not notable beyond the idea that there's a few people in that, even within that concentrated colorectal group, that have an enhanced experience with this particular problem. What is not discussed, and at least what I've experienced in my practice, and I think everybody on this call has, is there are isolated iliosigmoid fistulas. There's also people that have Crohn's-related fistulas to the sigmoid and the bladder and the vagina and God knows what else all at the same time. So this is a relatively select group of the many complications that we see with Crohn's disease. When I looked at this paper, what I noted in my head is that it's amazing that the results were the same for all the groups, or for the different groups. And what I wondered was, if you actually randomized people to, which you could never do, that's kind of the point of all reviews of technical outcomes. If you actually randomize people to different groups, you would probably find that in individual groups, in the hands of individual surgeons, there would be much worse outcomes for certain individual options. And the reason for that is because it would be the wrong thing to do at that time. So what my takeaway from this paper, from any paper that reviews retrospectively techniques across surgeons, across situations like this, is the compliment to the surgeons that they chose the right option at the right time based on presumably their experience to come up with a relatively, what I would imagine to be a low level of complications that cannot be gotten below. And what that means is that surgeon's experience is important and surgical judgment is important. I don't know that there is a takeaway in technique in this, that this is what we should all do. I agree with the authors when they say, if possible, to make a complicated operation simple. If you feel like you can simply staple off or pinch off a fistula to the sigmoid colon and oversew it, it is better than trying to do a resection when you might not have to. But I think really it's about the selection bias when you're in the operating room at the time for you to discover what you think you can do, and not taking away from this, there is one technique that is better than another. You just have to be able to be prepared to do all of them. But I don't know what else we could conclude from this paper beyond surgical judgment at the time of surgery makes a difference.
Thank you. There's a few very, very valid points there. One of the things I notice is that there's so much subtlety in the difference in pathology of Crohn's disease. And I take your point about people who have more volume and do more of this would appreciate those subtleties more. I have a question for Dr. Fichera, who would probably do as many as anyone, if not more. And my question is related to the relationship of the fistula opening in the sigmoid colon. Specifically, I think if there's a phlegmon of the ileum, the phlegmon's more likely to get stuck to the antimesenteric side of the sigmoid. Whereas if there is a true fistula, from my observation, the fistula seems to go into the junction between the mesentery and the colon. And that would, for me, make a primary repair quite prohibitive, and an anastomosis would be more common. So would you mind sharing your observation and whether you agree with this or not?
Well, thank you for asking the question, and congratulations on the team for a great review so far. This is the beauty of Crohn's disease, right? You're going in a way. I disagree with Dr. Cataldo a little bit. You go in not knowing 100% of what you're going to find, what you're going to do, and what you're going to recommend afterwards in terms of therapy. But it's the interesting part of Crohn's disease, and that's why these patients will need a colonoscopy before to try to get a sense of the sigmoid colon being an innocent bystander or involved, and the extent of involvement. It is all relative, however, because once you go in there and you start taking down these fistulas, it's really the quality of the tissues, the location of the fistula, and the damage to the wall that results from your surgical approach that dictates the approach. Obviously, an anti-mesenteric fistula on the sigmoid on a sigmoid colon that is a secondary innocent bystander can be closed transversely like a stricturoplasty. When you're starting to get into the mesentery, when you're starting to get a significant portion of the wall involved, I think it's safer to do a resection. Also, because if it is an innocent bystander, there would be a healthy bowel anastomosis, so on the sigmoid colon. So really not a big issue. So I do not have a one-size-fits-all, as was mentioned before, for this situation. I do like to have an idea that what I'm getting myself into when I go into surgery, but that scenario often changes quite a bit. Also because Crohn's disease is different 1 month to the other, and a imaging that you have obtained a month ago may not be representative of the intraoperative findings anymore. So I don't really have a simple answer to your question, but I think this is the beauty of taking care of Crohn's disease patients.
Thank you for that. Now, I've got one more question to the panel about this article, and then if there's nothing else from the audience, and I can see there's a few things in the chat bar, but if there's nothing else in the audience, we'll move on to the next stage. So my question is related to the rate-limiting steps of performing such cases in a minimally invasive surgical manner, whether it's laparoscopic or robotic. And specifically, what is it? The suturing of the bowel? Is it controlling the Crohn's mesentery that can be, very difficult to control? Is it the abdominal exposure? And at what point would you then make the determination to say, I'm not going to waste any more time, I think this is better to do open?
I can help with that. A couple of things. Number one, I want to emphasize that preoperative endoscopy is critical for these cases. I think that's number one. What you're getting into, innocent bystander or criminal, or call it whatever you want to call it. The sigmoid colon, you will know ahead of time whether you're doing most likely a resection versus a takedown of the fistula. In regards to laparoscopy, what I've seen and found is that you have to be very patient, and you have to dissect the fistula like you dissect a mesenteric vessel. You have to dissect it thin enough to be confident that you're getting the fistula and nothing else when you're transecting with that stapler laparoscopically, to close that fistula in the healthy side of the colon in case it is an innocent bystander. So laparoscopy is feasible. Now, if you're doing a segmental resection, I think, although it's going to be much more brutal as a surgery, I think just cutting through the fistula will expedite things, because there's no reason for you to try to dissect the fistula out when you know that you're going to be doing a segmental resection on the sigmoid part. So I think being patient during laparoscopy, the trigger for conversion is when nothing is mobile, when mesocolon is heavily involved, not with disease, but with the fistula. So you have no idea where that hole ends. And one of the, let's say, worst scenarios is that you do the takedown, you staple, and then you see that bubbles are coming out of the mesocolon of the sigmoid colon, correct? You have missed the fistula tract. And then essentially you're going in for a resection. Conversion to open happens when you go in and essentially everything is immobile. There's a lot of mesenteric edema or Crohn's related mesenteric involvement that makes things so difficult. Like I would say 50% of the small bowel mesentery is attached on the colon. It's very difficult to take it down. It's very inflamed. And then you should think conversion early. Otherwise you will be wasting your time and a lot of bleeding.
Thank you. Thank you. That's great. Now, without further ado, let's move to the results of the poll, and we'll get Stephen Brentstetter to shine.
Yeah, so I have the results here. Now, this is specifically in reference to one of the papers that wasn't presented, but is among the readings for this month. And it's also in reference to a paper from our esteemed editor-in-chief, Dr. Glandiak. This is consumption of opioid analgesia in the 6 months before IC resection for Crohn's disease is associated with adverse outcome. So the question to the group was, what is the time in the patient's care to address this? Prehab, just before induction or post-operatively, never always, or other. We did not have a list, unfortunately. But this is the results. So prehabilitation was certainly seen by the group as the dominant strategy for how to effectively intervene in this opiate use.
Thanks, Stephen. We're fortunate to have Stephen OBrien on the line, I think, who's the first author for this paper. Stephen, thank you. I think you're from Ireland, if I'm not mistaken. So you're suffering with the time zone crisis, just like our special guest, Dr. Messaris. But if you can possibly maybe just highlight some of the salient points from the paper, and also your opinion on the prehabilitation versus other steps in the surgical pathway.
Yes, of course. Thank you very much for allowing us the opportunity to be part of the journal club. So I suppose looking at this manuscript came about as a discussion in one of our lab meetings between Dr. Glandiak and Dr. Polkin. We noticed that a lot of the patients in our region were they had there was a large variability in the consumption of opioids. Obviously there is a need for adequate analgesia control in these patients, but it was something that we thought, is this something that we could potentially intervene on? And I do think in the era of prehabilitation protocols, I mean I suppose maybe we'll be biased, but I would think that is probably the most likely way you could intervene on this, using different multimodal strategies, like what's being done up in the anesthesia in Michigan. It is a potential area in which it can be intervened on and decrease the consumption of opioids. Essentially, then with the benefit of helping with the eventual outcome of decreasing adverse outcomes in patients.
Thank you for that. I just want to unpack the top 3 of those responses, maybe some opinions from the panel. So if we talk about prehabilitation, should we view it as analogous to a steroid way, tapering? And how do you actually do that? Do you employ a psychologist? Do you you write out a prescription for the patients to wean it? Or what is actually practical, do you think?
Dr. Cataldo, do you want to weigh in on that, given our recent patients we've dealt with?
Sure. I mean, the way I look at it, because we've spent a lot of time in our office thinking about frailty and some time thinking about prehabilitation. I think the world of these people, same as people that are malnourished or on steroids, is you either have the opportunity or you don't. There's a huge fraction of people that would be really, really nice to prehab, but you don't have the option because of a variety of things, right? So if you eliminate all of them, then there's the willing. And if the willing, if you have the time and the patients are willing, then that also, there's a selection bias there too, because most of the people who have the time and are willing would have already done it sort of on their own. They're doing their best. So there are a relatively, in my view, a relatively narrow band of people that are not doing their best, that you have to convince them to do their best. And that same thing goes for nutrition as it goes for opiates. People really do enjoy their opiates. If they're already on them at a baseline, again, there's a huge selection bias here, but if you can get them off it and demonstrate to them, you know, that it's beneficial, there is a narrow band of people that will do it. And if they can, and they will, I think it would be great, and we try, but I think that that is a relatively limited population. Just like people who are smoking, right? We tell them to stop smoking, but I've never had the privilege of being addicted to tobacco, but they say it's as bad as heroin to try to stop.
It's interesting about smoking because that was one of the other papers that we shared this month. And I mean, I think the disease process of Crohn's is significantly different to some others, but perhaps we should look at the hernia surgeons and how they've been quite militant in sort of controlling who gets elective surgery if they're a smoker. But that's for another day. My next point
Vlad,
is...
can I just comment? I think one way to help with opioids is to discuss just a stoma, a diversion proximal to the disease, and try to control the pain that way. Wean them off then for a larger surgery down the road once they can wean down on their opioids, if they can just get a diversion, if that's possible, if it's perianal disease or colonic disease.
That's a very interesting point. Thank you. Now the next point is about prior to induction. Now I presume significant amount of issues with opiates is related to post-operative ileus. Now, does the panel subscribe to sort of alvimopan as a preoperative treatment for these patients or not?
We, as a group, we have decided that we don't think alvimopan is so that much beneficial. We don't believe the data is there. It has been conflicting at times. We have a pretty standard, aggressive, and compliant enhanced recovery protocol. And actually our patients go relatively early home with one of the shortest length of stay and without using alvimopan. So we do not.
Okay, thank you. If there's any other comments, if you can put them in the chat just for interest's sake. Last point about the poll is related to post-operative interventions. I remember when I was Luca Stocky's fellow, he used to like giving patients post-operative tap blocks, and he felt that as far as I understand, potentially the psychological effect of having a tap block when you're awake and identifying a change in pain levels might be more helpful than having it intraoperatively. What does the panel think about that? Do you implement post-operative sort of local anesthesia?
We are huge fans of tap blocks. I think it is literally a universal for us.
But intraoperatively versus post-operatively, do you think does it change?
We do it at the, I mean, almost all of us do it at the end of the case. The last thing we do before we close the fascia is, at least I'm speaking for myself, do a tap block.
I do it at the beginning of the case based on the data from cholecystectomies to try to decrease the inflammatory response during the case. And fortunately, we use simple bupivacaine. There are some studies conflicting about liposomal bupivacaine. Some studies say that it helps, sometimes it does not. Actually, I'm interested on what you said in regards to, there is going to be a placebo effect with the patient awake, providing this analgesic medication as a, invasive intervention at the bedside. I think it would be difficult to do, but somebody did it.
Well,
And
we published our own randomized trial on exactly that. And doing postoperative tap blocks, one results in a period of postoperative pain in the PACU, which is difficult. And it imparts an expense, both a professional expense and ultrasound and a bunch of other stuff that is unnecessary. There is doing it at the time of surgery, regardless of whether it's done at the beginning or the end, is as effective as having anesthesia, if not superior, but we couldn't prove that, as effective as having anesthesia doing it in the PACU, or while the patient's still under anesthesia. I mean, it was purely isolated in our study to the technique. So the patient was under general anesthesia, both cases, whether it was done by the surgeon laparoscopically or whether it was done with anesthesia under ultrasound. But I think if you do it in the PACU afterwards, there's a period of pain that gets that patient into the post-surgical pain cycle that sort of mitigates the value of the tap block.
I think it's a fantastic discussion. Thank you for those wonderful answers. I do it in the start of the case based on my limited ability of remembering to do it later. Now, the next stage is our special guest segment. And we're indebted to have, obviously, Dr. Messaris for this. He was very well introduced by Kristen earlier, but I'd just like to reiterate that he's an associate editor with the DC&R journal, and he's, of course, the chief of the division of colorectal and rectal surgery in this department. So the things I want to discuss or pick your brain about is related to stricturoplasties and Crohn's disease. We haven't discussed that in Journal Club yet. And the first question is, for ease of differentiation, we divide strictures into fibrostenotic and inflammatory strictures. Can you just share your view on which strictures are amenable to stricturoplasties, and how do you determine that preoperatively and intraoperatively?
Yeah, thank you for the question. So, I mean, the first modality preoperatively for me to identify whether this is an inflammatory or fibrostenotic stricture is an MR enterography. And it is equivalent in diagnostic for diagnostic purposes with a CT enterography. But of course, the MR has no radiation, and we know that patients with Crohn's disease will have too many imaging modalities over their lifetime, so avoiding a CAT scan is great. I expect on the MR to see whether there is a T2 signal that will show inflammatory changes in the area of the stricture. And in that case, I'm trying to understand whether this is an inflammatory or a fibrostenotic stricture. Another assessment is clinical. If the patient gets steroids and the obstruction resolves completely, then you know that you're about to deal with an inflammatory before the surgery, stricture versus fibrostenotic. And instead of steroids, you could use biologic, the same thing. If the patient responds, then you wait. In regards intraop, I think the size of the stricture matters. For the small strictures, most of the times, either inflammatory or fibrostenotic, you can do a stricturoplasty. I think mesentery, as Dr. Raskin said, is critical for the decision-making. If the stricture is covered completely with mesenteric fat, I don't think it's safe to do one. It's an inflammatory stricture most of the times in that case. I don't think it's safe to do one. If otherwise, inflammatory or fibrostenotic, it's in both cases, it is feasible, and it is because you have to reach a 1 centimeter normal tissue on each side to do your stricturoplasty. So it is feasible. Now, for long segments, I'm talking 20 centimeters, where usually you would do a resection If you cannot do a resection, most of the strictures are inflammatory, with involving large segments of small bowel, and in that case, rarely you would proceed with a Michelasi structuroplasty, or if it was smaller, with a Finney. And in that case, again, most of the times it's inflammatory. Sometimes it's fibrostenotic, and you proceed with the intervention.
Thank you. Sometimes it seems to have like a badge of honor of how many stricturoplasties you can do in one patient. Now, what do you do when you're faced with multiple strictures in a with short intervening healthy parts of ileum or small bowel? Do you join them together? Do you do 10 different Heineken in a 20 centimeter segment, or how do you approach that?
I think there are many factors to make that decision. Patient's age, patient's previous surgical history, patient's length of remaining small bowel are critical. I just want to point out here that before any inflammatory bowel disease case, I measure the length of the small bowel, and I put it in the operative report for myself, for the next surgeon that's going to operate on this patient to know. I think that's one of the most critical parts for IBD surgery. So going in, you assess the length of the bowel and you make a decision. If I have on a 50-year-old patient with 5 strictures within 20 centimeters and in a complete small bowel, I would do a resection. I think it's faster, safer, and the chances that the patient will develop some kind of a malabsorption, malnutrition, or short bowel syndrome in their lifetime is minimal. So I think that's the best possible procedure for this patient. But if you have a 20-year-old that has had already 3 ileocolectomies, has 200 centimeters of bowel, and you're counting every centimeter that you use, in that case, I would argue for 5 structuroplasties. So I don't think there's a quick answer to your question. And I always struggle, to be honest, because we have 2 or 3 of these questions either at the board of the or the ACS thing. You always get it, and if you don't have all the information, so I think pretty difficult to make a quick decision. Now, and this is for small strictures that are separated by healthy bowel. Now, if this is a long segment, as we discussed earlier, then we are having threatened bowel, then we would do some kind of a structuroplasty, either Finney or Michelasi.
Thank you. Philosophically, I sometimes wonder what has a more greater propensity to leak. Is it the length of the stricture, like the actual centimeters, or is it the frequency? So if you have a 10 centimeter structuroplasty, which is a Finney, is it more likely to leak than 3 Heineken, which are like 3 centimeters each? But what do you think is, what do you quote patients, or in your mind, when you do a stricturoplasty, what do you think the leak rate is? And is it different from an anastomosis in the same, patient?
If we take into account, we take away malnutrition and other risk factors, steroid use, long-term steroid use, more than 20 milligrams, I would say that structuroplasties, especially the short ones, are safer than a full anastomosis. I would quote the patient 1 to 2% structuroplasty leak rate. I quote 5% for anastomotic leak rate. I cannot tell you that I have an opinion whether the number matters or not, on how many you do. I think a lot of factors play in, but usually I feel safer with multiple small strictureplasty and one anastomosis, as long as they're the typical Heinke mycolids. Now, Dr. Fiquera is on the line. I just recently did a Colon 17 centimeters in length. It took me an hour to do, and afterwards I was pretty, thoughtful about, okay, 17 centimeters. The chances just went up that I'm gonna have some kind of an anastomotic leak. Thankfully, it didn't happen, but you always have in your mind. But I think it is more the fear than the actual facts or events. We don't have enough data in this area. Strictureplasties are more rare as we move on to the era of biologics. And, biologics do not prevent surgery, but they definitely delay it. So you decrease essentially the frequency, you increase the frequency, the interval between surgeries for these patients. So I think strictureplasties are slowly declining in numbers among patients with Crohn's disease. And the disease involvement of the length of the bowel is usually less than what it looked like 10 or 15 years ago.
Okay. Thank you. Last time I was allowed to leave my country and go to a conference, I remember speaking to a pharmaceutical rep about a medication called Gattex, which, if some people in the audience might not be familiar, promotes mucosal growth in short gut syndrome. Now, you've talked about sort of measuring the bowel and being prepared to resect versus do a long strictureplasty. Does these new medical therapies affect your decision making?
Let's start with, there's no conflict of interest here and with anybody in at least the division. Let me start with Gattex should not be given on patients with any kind of bowel obstruction or stricture. That is a direct contraindication to receive the medication. So the answer is no. We do not think of Gattex before. Sometimes I think of Gattex after the operation when we've left the patient with, the numbers are, variable for everybody, but I would say 150 centimeters without colon or 100 centimeters of remaining of small bowel with colon can lead you to either fluid dependency at home or TPN at home. If you end up with a patient like that, that develops malabsorption syndrome, short bowel syndrome essentially, with malnourishment or need for constant fluids or TPN, then Gattex, as long as the patient doesn't have a history of cancer, significant cancer in the GI tract, Gattex is an option. It occurs, I would say, once or twice a year, and it has helped a lot of patients get off either the fluids or move from TPN to fluids, or decrease at least the hours of overnight fluids or TPN, so that they can have a better quality of life.
But just clarifying, intraoperatively, where you're confident that you've excluded a stricture on obstruction, does Gattex make you favor a resection over a strictureplasty, or is it at the moment completely?
No, because even the data from the studies for Gattex showed that there are some patients that are going to respond and some patients that will not respond. So I do not base the decision making on whether Gattex is available or not.
Okay.
But I definitely think it if the problem arises later on.
Thank you. You've mentioned factoring in the colon when you're talking about short gut and general absorption length. Is there a role for colonic strictureplasties?
I do think there is, but I think it is, again, in a very specific population. Short colonic strictures, let's say on a patient, I'm giving examples now because I think it's important, like, 3 previous ileocolectomies. Now the last anastomosis is between ilio mid-transverse colon. and you have a stricture in the splenic flexure, which means if you're going to do a segmental, you're going to end up with essentially left colectomy with an iliosigmoid anastomosis. In that patient, you mobilize the splenic flexure, and you can do a stricturoplasty if it's a short segment stricture. That would be possible. That's a rare case, very rare, but that's a way to avoid, not sparing as much as colon as possible for water absorption. That at least could take this patient from, not needing fluids for the rest of their lives overnight.
But you have to rule out a malignancy. Colon strictures are different.
Small bowel.
Thank you.
That's a great point. Small bowel, not just colon. Small bowel strictures, stricturoplasties have been always the fear of a stricturoplasty is monitoring afterwards for malignancy in the area. The data has not proven that that's the case, but always you have to exclude a malignancy in any stricturoplasty you do.
But I mean, I'm saying like colon cancer is far more common than small bowel cancer at a baseline. So, I mean, I think that if you're going to do it, you better be absolutely sure, even including taking a frozen.
Thank you. And I think that's, oh yes, there's a question from Dr. Fichera about sending a biopsy when you do a stricturoplasty. I think that there's a paper from my memory from the Cleveland Clinic on this from a few decades back, but what do you do, Dr. Messaris?
So first, if it's colonic, most of the times you have had already endoscopic either balloon dilation or some kind of thing and a biopsy from there. If it's small bowel, usually I do not send, but of course I closely observe the mucosa. I mean, you have all the bowel exposed in front of you. If there's any question, I do a resection. I would not proceed with a stricturoplasty, and I would not send a frozen. I would do a resection if any question of mucosal abnormality that would suggest a malignancy. Usually, to be honest, in the area of the stricture, there's no mucosa at all. At the source or the center of the stricture. So there's a linear ulcer or something like that. You watch it. If it's smooth, you continue. But there is always the risk, and I'm not saying about the stricturoplasties, even for fistulas, anal disease, when it's very chronic, the chances of a malignancy are high. Also, we didn't discuss about the bypass, which is another way out of a big problem. And that bypass segment is, I think, the highest risk for developing any kind of malignancy in your lifetime, especially if you forget it, patient does well, and you leave the bypass segment like that, and you can get a cancer 10 or 15 years later, and all the patient's doing well and suddenly develops a small bowel cancer in the bypass segment.
That's a fantastic point. I certainly haven't thought about that, so thank you. Now, this probably ends our discussion. Thank you very much. If you have any last-minute tips you'd like to share with the audience, Dr. Messaris, that would be fantastic. But otherwise, I think we've had an excellent hour, so thank you.
So first of all, I want to thank you. As I said at the beginning, you have changed the journal clubs for all of us, and you have made it a national thing. All the fellowships can share the same information, so thank you for that. Last minute tips, I would say preoperative preparation is the most important in patients with IBD. Appropriate imaging, appropriate endoscopy, intraoperatively, especially in the area of laparoscopy, and Alessandro again is here and we can discuss this because we have discussed in the past. I think you need to be sure that the bowel that you examine and you run does not have any missed strictures, especially with laparoscopy, because you can miss a stricture running the bowel from the ligament of Streids down to the iliocolonic area, using the Foley with a small balloon to rule out the strictures, like inflated with 5 cc's and run it through the bowel, even through a small opening with laparoscopy. It is feasible and will help you, will save a patient, a missed distal stricture, a missed proximal stricture. And prehab, I think, is critical also in these patients. Most of the times you have the time, it's not a cancer, you have the time to prehab a Crohn's patient and alter their overall outcome. Thank you.
Thank you. Now, one last thing I wanted to mention is that one of the faculty members, Anne Fabrizio, I think, was so keen on Journal Club that she went into labor. So I wish her the best. And Vlad, if she's listening, is an excellent name for mostly boys, but potentially also girls. Okay.
It's a girl and her name is Juno.
It's not too late. That you can always have a middle name. Okay. Margaret, could you just put the last slide on, please? Again, thank you all very much for attending. Now we will strive to continue these journal clubs every month, and please follow us on either Twitter or have a look through the website of the journal. And again, very grateful for this excellent faculty from Boston that has helped us today. Okay, thank you all.